Welcome back to Psychedelics Today. Today on the show we have Dr. Scott Shannon, who's a psychiatrist working out of Fort Collins, Colorado, actively working with ketamine. Very interesting character. I think you guys will really love this show. We really had a lot to chat with him about because he has kind of a long-standing interest in psychedelic medicine and some orientation with transpersonal psychology. And a really interesting fun fact, I forget if it was in the show or not, but really Dr. Andrew Weil from Arizona is the one that turned him on to MDMA therapy back in the 80s when it was still legal. And it was, just a really great conversation, really appreciative of Dr. Scott Shannon's time. I can't wait to get up to Fort Collins to record in person with him and bring you guys another episode. So really hope you enjoy it. Let us know what you think. You can hit us up at Psychedelics Today, email at gmail.com, contact page on the website, or hit us up on Facebook, Instagram, Twitter, Pinterest, whatever, YouTube, some other places too. And if you can, leave us a review on iTunes. We'd love it. Thanks. Bye. Kyle and I decided to run another book giveaway contest. We're giving away a ton of stuff here, and all you have to do is give us your email. You can sign up over at psychedelicstoday.com. It's called the Ultimate Psychedelic Book Giveaway. Probably close to $350 worth of stuff. Let me read off the list of stuff you can get here. Brotherhood of the Screaming Abyss, Dennis McKenna. LSD, My Problem Child, Reflections on Sacred Drugs, Mysticism, and Science by Albert Hoffman. The Psychedelic Explorer's Guide by Fadiman. P-Call, A Chemical Love Story by the Shulgins. Dirty Pictures about Sasha Shulgin. LSD, Doorway to the Numinous by Groff. Adventures of Self-Discovery by Groff. Healing Our Deepest Wounds. The Ultimate Journey, When the Impossible Happens, and Holotropic Breathwork, all by Groff. And that last one was co-written with his late wife, Christina. And you get a seat in our class, Navigating Psychedelics, Lessons on Self-Care and Integration. More on that soon. You also get a Psychedelics Today t-shirt and mug. Yeah, we're roughly guessing this is about $350 worth of stuff. If you want to sign up, check us out, psychedelicstoday.com, and you'll see the link for a giveaway. You'll see my face with holding some books. You just click that and you get there. The more you share, the more you increase your odds of winning. Some folks have shared it all over Reddit, YouTube, various forums they're in, and it really has increased their odds of winning. So you just, we'll email you a link after you sign up. You share that. The more people that sign up through your link, the more chances you get to win. The contest ends January 1, so make sure to get your entries into the contest before then. Best of luck. Kyle and I decided to raise some funds using Patreon, which is a really cool way to support the show because you can choose to donate a small portion of money monthly for certain prizes. We are allowing you guys access to interviews before they will ever hit the web. So, for instance, this Horizons episode, they've had that for a few days. And I believe there's some panel discussion stuff we've recorded and made available there. You'll probably also have access to some member or patron-only webinars. We also have rewards including t-shirts, stickers, mugs, access to our Navigating Psychedelics class, and much more. So check it out, patreon.com/psychedelics today, or you can get a link from our site, psychedelicstoday.com.
All right, welcome back to Psychedelics Today. Today we are joined with Dr. Scott Shannon of the Wholeness Center out in Fort Collins. And Scott is here to talk to us today about ketamine. So thanks for coming on the show and sharing your wisdom with us.
My pleasure, Kyle. Happy to be here.
So let's just kick it off and give a little background about your work and who you are.
Well, I'm a psychiatrist, integrative psychiatrist, and I've been working in holistic integrative medicine for 35 years. And interestingly, I sort of got kicked off into this field and actually an interest in psychoactive substances. My first mentor was Andrew Weil in Tucson in the early to mid 70s. He was unknown at that point, but my mentor, I was a psychology undergrad at the U of A in Tucson, and my mentor, who was doing mostly behavioral work with rats, when I expressed interest in studies of consciousness, said, "You should go talk to this guy out in the desert." So I went to talk to him, and he was also very interested in holistic medicine, but he helped to trigger my interest in MDMA. And so soon after graduating medical school in the early 80s, I began to work with MDMA legally with my practice and with friends both, and found it just a phenomenal tool. Was sort of very disgusted and disappointed when it was scheduled by the federal government in 86 or 87. And then went on and sort of got lost in a variety of things. I went and did training in child adolescent psychiatry after my adult psychiatry residency. And then came up to Colorado and just got plugged in with doing the work up here and sort of lost track of psychedelics for about 20 years. And then about 5 years ago, a buddy of mine, a psychiatrist in Boulder, Will Vanderveer, told me he was beginning to work with MAPS. And I'd been a member of MAPS since the early 90s, the Multidisciplinary Association for Psychedelic Studies, doing some work with MDMA. And I said, "You're kidding me." And so we developed an interest and put in an application, and we're now one of the phase 3 sites for the MDMA trial in PTSD. And sort of simultaneously, I rekindled my interest in ketamine and began to do a little bit of work with intranasal ketamine with a couple patients. Saw some interesting changes, and then realized I really needed to know more. So we got some training, went through some due diligence with our clinic. I work at a comprehensive integrative mental health clinic in Fort Collins, where we work side by side with naturopaths, neurofeedback therapists, biofeedback, acupuncturists, do a lot of food nutrition work, a lot of work trying to minimize the use of psychiatric medications, because I just increasingly feel like it's a fading paradigm, and the suppressive tools that we use in psychiatry, things like benzodiazepines, antipsychotics, actually look like in the long run they make people worse. So I was really looking for things that work in a more evocative model, which is trying to bring up what's inside the person instead of trying to suppress what's inside the person. And ketamine just seemed to fit the bill. And ketamine was also legal. In spite of my interest in other psychedelics and MDMA, those are not legal at this point, and we're trying to push ahead with research. But ketamine is really a tried and true medicine that's used around the world. It's valued, it's got a good safety record, and I think it's a wonderful tool for treating people. And so at our clinic right now, we have 3 different modes that we use. We use IM injections. And in that case, the patient comes into my office, we have a brief discussion, I give them an injection, and then as they're coming out of the experience, usually 25, 30, anywhere up to 40 minutes really, then we begin to process what happened for them. The other option is they can get a IV intravenous option, and they tend to go into one of our IV rooms. And that experience is a little more, it's not my preferred mode, but some people it may actually be the best mode. They often just sit there with headphones and blinders on, have their 40 to 50 minute experience. I check them out, process with them briefly, and they go home. The other option is working with oral ketamine, sublingual methods. We do sublingual in the office first to sort of get a sense of how much is needed and what their response is going to be. Then they can go home and do that once a week. And I do this only with people that I have a good rapport with and a sense of trust with, because it could be dangerous, and clearly it's an abusable medicine. That's what we're doing, and we've been doing that now for 5 or 6 months, and I am just devoting more and more of my practice to it. And I think it's really a wonderful, adaptive, creative tool. And as I was mentioning to you before we went on, I just came back from a 2-day conference on ketamine with physicians from actually around the world there. And what I found out is there are now 1,000 physicians in the U.S. prescribing ketamine or mental health indications. And the amount of people being treated yearly is just rising geometrically, so that this has increasingly got a strong presence in psychiatry.
That's amazing. Do you know the history of like how it got involved in psychiatry versus say like veterinary medicine where they're using it as an anesthetic?
Well, brief history. I think it was discovered in 62 or 63, and it's analog, a slight derivative of PCP, phencyclidine. And phencyclidine is a dissociative, which turned out to have too much behavioral overlay to have a lot of value in anesthesia. So they were looking for a drug with maybe sort of a calmer response, so to speak. And they discovered ketamine, and came on strong in the 60s as a dissociative anesthetic. And by dissociative, what I mean is it sort of disconnects the body from the brain. And it's not actually a psychedelic agent, although at high doses, people will have psychedelic-like experiences. Then in the 70s, late 60s, people like John Lilly, a physician and just kind of a very interesting guy, began to get interested, began to have a track record a little bit of his drug of exploration, and then concomitantly a drug of abuse. But it has spread far and wide. It's now an ideal battlefield anesthetic. So in active combat situations, if your buddy has his arm blown off next to you, you can give him an injection of ketamine, and he will be anesthetized until the helicopter can arrive in 20 minutes without having to worry about breathing or cardiac effect. It's used in pediatric emergency rooms. If a 5-year-old cuts his forehead, they often give him what they call a rhino dart of ketamine, and often at doses like 2 to 4 milligrams per kilogram, which is quite a bit more than we're using in psychiatry. The young child will be put down enough that they can sew up the forehead without having to put him into general anesthesia. It's used in veterinary medicine because you can anesthetize a horse and not have to worry about respiratory arrest or complications of needing to ventilate a 2,000-pound animal. And it's still used pretty widely in anesthesia. It's being used to treat chronic pain syndromes. It's being used to treat chronic severe headaches. And one of the interesting things that's being used in chronic regional pain syndrome is they're putting people into a ketamine coma for 2 to 4 days at a time and finding that it can break the pain syndrome. But so it's just widely used in medicine, and it has a great track record.
Yeah, it's a Schedule 3 substance, so there's a lot of like off-label use. That's where this, like the psychotherapy aspect, using it for like psychiatric disorders comes in.
Yeah, and I think what happened somewhere in the 90s, an increased number of anesthesiologists would note that after a patient came out from ketamine anesthesia, they saw that their mood improved rapidly. And they saw that they were often euphoric, and some noted that people's suicidal thoughts seemed to melt away. So soon after, in the 2000s, psychiatrists began to evaluate it, looking at IV ketamine, usually done at 0.5 milligrams per kilogram. And I'd say that 90 to 95% of the research in psychiatry has been about that. But Suarte of NIH published a large study of IV looking at the euphoric response in people with depression and found, and I think the research is pretty clear, that it bumps mood and really seems to melt away suicidal ideation. But those things seem to fade often in 3 to 5 to 10 days. So in psychiatry, what's being done now is regimens of twice a week for 3 weeks, looking at oral maintenance or IV maintenance. And that's really where the creative aspect now is in psychiatry, is finding out what can be done to maintain the response. So it's a really exciting, interesting area.
Could you give us like maybe kind of some sort of anonymized case study of a patient that had a great result?
Okay. The first patient I used with this was a patient that had been treated by a number of practitioners at our clinic, 67-year-old guy. He had been depressed for probably 40 plus years. And over the last 10 years, had become so depressed that he was mostly just shuffling around. It looked like he had Parkinson's disease, sort of like Muhammad Ali. And he was just sort of shuffling with his shoulders stooped over, said very few words, his face didn't move, and he was just horribly depressed and felt suicidal all the time. He'd been tried on probably a range of 12 to 15 different psychiatric medications. And at this point, they were looking at sending him to ECT because he was what we call psychotically depressed.
Is that electroshock therapy?
Yeah, electroconvulsive therapy, electroshock. So he was sent to me, and he seemed very interested and excited about it. His partner was supportive and willing to be present to pick him up after sessions and be supportive. So he came in for his first session. We gave him an IV session, and he brightened up. Afterwards, he came out a little euphoric, smiling. At that point, he was no longer suicidal, and we scheduled him for another session about 3 days later. By the time he came in 3 days later, he was still feeling depressed, but not quite as depressed as he's been, but not quite as euphoric as he was right after the treatment. No feelings of suicide. So he went through and had a few more IV treatments, and it seemed to give him a bounce each time that seemed to sustain. And finally, after 6 sessions, he was smiling, joking with staff, and just remarkably better. His Beck depression inventory, which is a measure of severity of depression, went from like 47, which is a very severe depression. He was immobilized, unable to function, couldn't even do simple tasks, couldn't drive. And when we finished up, he was in the high teens, so mild depression perhaps. Probably you bump into a lot of people on the street that are functioning at that level. And no suicidal ideation. And right now he's currently doing 1 oral treatment at home each week. Lasts about 2 hours with his partner in the room. And says he hasn't felt this good in 40 plus years. He's joking with staff, interacts normally, is beginning to think about, more action and more involvement, getting back into some of his old hobbies. So it's actually a dramatic response. So that's one case I'd say that is sort of blew me away by how completely he's responding. He's now probably 4 months into this, so this is more than just a blip on the screen.
That's fantastic. Yeah, that kind of depression, I don't usually see people bounce out of it without intervention of some kind, and it's really cool that we have something so promising right now. And like you said earlier, 1,000 physicians in the States. Do you think North America or the States providing ketamine?
I think the laws in Canada are funny, and I've heard of people that are exploring, but I'm not positive that ketamine is I think it is being used in Vancouver. So I think it is being used in Canada. I did find providers. I had a patient come to me that I treated from Mexico, and we were sending him back to Mexico City. We found researchers who were doing ketamine in Mexico City at the university there. And I think this is happening around the world. We had a presenter come present at this ketamine conference from New Zealand. I think it's an international phenomenon at this point.
It's fascinating. Is any of the research or science kind of pointing out the mechanism? Like why does it treat the depression and suicidality?
Well, there's a few different points of view. You have the biochemical neuropharmacologists who say it's an NMDA receptor, not unlike lamotrigine or Lamictal, which is a well-used medication in psychiatry. And interestingly enough, we often find we have to hold that medication if someone's on it before we give them a treatment, or otherwise their response is quite blunted. So that's one method. Another method is looking at this as a psychological impact, in that people have a profound alteration of their consciousness and experience, often with transpersonal elements that reshifts how they view the world, themselves, and their sort of depressive journey, if you will. And there are actually a number of studies that show that the depth of response seems to correlate with the dissociative effect created by ketamine. And actually, others have found that the mystical quality created by ketamine also seems to correlate with treatment response. So at this point in psychiatry, you really have 2 warring camps. One camp says it's just the drug, it's just the neurotransmitters, just give them an IV, send them home, and they'll be better. And the other camp, which I think I'm a part of, is that this is an intrapsychic tool for exploration. And although it's not a true psychedelic, it gets deep into the psyche because of its dissociative effects and really significantly stirs the pot. What it does is it seems to turn off the cortex and turns off the whole default mode network, which is our personal narrative, our story of who we are, what's going on in the world for us, our likes, dislikes, our political views, any particular people in high office that we might dislike, etc. And that goes away with ketamine. And I think for a lot of people, they end up running such negative loops in their brain about how they're a horrible person, or life is bad for them, or why should they live? Maybe they should be dead. And it turns all that off and allows us to sort of reboot, just like you would turn off your computer, or maybe more accurately, turn off your phone and shut down unwanted apps that are running and sucking all your power. So it's an interesting time, but it's a time of exploration, and I'm really excited to be involved in it.
Yeah, that's interesting. So it's kind of doing the same thing as psilocybin, where it's shutting off that default mode network or decreasing blood flow to that area.
Yeah, so the difference is with psilocybin, it shuts down the default mode network, but the rest of our cortex is running. So we can talk, usually. We can look at things, usually, and navigate to a degree in the world. Ketamine is quite different in that it's non-selective, and it just shuts down the whole cortex.
Okay, interesting.
And because of that, it shuts down the amygdala, but it also shuts down a lot of other areas of the cortex. And the amygdala is the fear center, and we think that's why we can do some very interesting trauma work with ketamine when people are experiencing a ketamine infusion or injection, just like we can do with MDMA. MDMA, people have good cognitive clarity, so you can actually do very profound psychotherapy during the experience. Whereas with ketamine, very often we're doing the processing when they come out of that experience because it is so incapacitating to the cortex as a whole.
Right. And MDMA is also kind of shutting down or decreasing blood flow to that fear processing part of the amygdala, correct?
Yes. Yeah, it shuts down. And at the same time, the MDMA creates a release of oxytocin, the bonding hormone, the love hormone, and it creates a release of serotonin, which is a soothing and calming effect.
Fascinating. Yeah, I'm kind of in the camp with you, and that's kind of my theoretical framework is working with transpersonal experiences. So that's what I was like maybe thinking about why ketamine could be effective is these transpersonal experiences giving you some sort of insight on what's going on in your life and kind of reframing that narrative a little bit. But I've never had experience with ketamine, so I don't know what the experience is really like. Could you maybe describe what an experience is like for folks?
Yeah, I've been to a couple of in-depth experiential trainings with ketamine by physicians who've been using it. Actually, a very interesting man who has worked with ketamine since the early 70s when it first came into the U.S. in terms of a psychological view. But in ketamine in high doses is really a profound and different experience, unlike any other psychedelic that I've experienced, encountered, or heard about. And what I would say is that ketamine, the feel is at times, unfortunately, a little bit mechanical to me, but I describe it as a kaleidoscopic, pixelated Legoland with machine-like qualities. Colors can be vibrant, colors can be intense, but there is really no sense of me, Scott Shannon, having an experience. I am merely conscious and alert that I'm merely an observant in this process that's going on in my body, in my brain. It's fascinating, it's profound, it's different, it's unlike anything I've experienced, but there's no sense of past or future. There's no sense, frame of reference of this reminds me of X or this reminds me of Y. It's just like you're immersed in it. Everything else is turned off. It's very encompassing and profound. And when you pop up out of it, is interesting. In one of my first training experiences, I got an IM injection of 0.5 milligrams. And I was told that it's probably going to be like 2 glasses of wine. And I had this profound, and I'm probably sensitive to these things, but I had this profound altered experience that is unlike anything I've ever had. But it wasn't fear-inducing, and I can be prone to anxiety in some wilder states, but this was not anxiety-producing at all. And I came out, in fact, laughing, saying, that's no 2 glasses of wine. So it's profound, and I think because of that ability so completely alter our awareness and frame of reference that it can have these transpersonal and psychospiritual impact. And I think begin to bring people into a mystical type experience.
That's really interesting. You say Lego kind of land, because I think when we had Shane Lemaster on, I think he described it the same way, kind of like this Lego block land that he enters into.
Yeah, it's got an odd. There's not quite machine-like, but it's pixelated would be a strong word that I'd use to describe it. Colorfuls, lots of reds, yellows, and greens. But I, for one, did not have images, voices. The music was quite important. And one of the psychiatrists in our building has now said that he won't have anyone go through this experience without music plugged in, because he thinks it leaves them hanging a little bit too much. And the music is interesting because the music gives you a little bit of a vehicle to go through this journey on. It kind of is a bit of a, I don't know how to describe it, but it's merely something that you can grasp onto as you shoot through the rapids. And it is deeply comforting. So I think music is clearly important as part of this.
Last time we spoke, you mentioned that people, when doing IV, have to go to a special room due to OSHA standards. Like the room has to be non-carpeted, hard surfaces. Are you able to provide music in the IV scenarios through headphones or small speakers or something?
Yes, we predominantly use headphones. And, you know, these days, most people travel with headphones. So I have a pair of noise canceling over-the-ear headphones, but most people are just used to using their in-the-ear buds with their iPhone or whatever. And, you know, one of the things, we've allowed people to select their own music if they want to. And it seems to be most people under 35 or 40 want to select their own music. And most people over 40 want us to do it. And I'm increasingly believing that we can direct and somewhat channel the experience by the musical choices that we make. And that's an area that I'm increasingly interested in. We'll be putting more effort in just to make sure that people get the right carrier wave, if you will, for their experience.
Yeah, it's really interesting. Joe and I have a background in breathwork, and music's a huge component of the whole experience, kind of guiding a person through it. And yeah,
it's a weird way to phrase it. It's non-directive guiding. And it's like, and drugs are obviously very different from a breath experience. We actually have to like initiate the organism into that state, as opposed, well, partly through music.
Well, and like breath work too, I think that set and setting is huge. Expectation is huge. I have a 10-page informed consent form that I really want to walk people through, not just the sort of mechanics and dry doctor talk boilerplate, but I really want to let them know what this medicine is capable of, what some people experience, what it's like, what to expect before or after. And I try to set up my room in a way that's pleasing and comfortable. I try to build rapport with people. I try to set up expectation with people that this will be a positive, profound experience for them. This has the potential to be deeply healing, and that I'm there as a support and safety. I really think that, like most of our deeply psychoactive medications, setting expectation and support are crucial.
Yeah. And it would be very interesting to figure out how to do some sort of research study on the music, like how to program it well or something. That would be an interesting thing to have a conversation with some.
Well, there's one existing study. At this point, I think our research really needs to prove that music with one of these medications is better than the medication without music. And there was one study that I saw, I think it was Robin Carhart out of England. One of his studies with LSD, I believe, found that with music, they saw more significant imaging in CNS changes on LSD. So that's the only study I know of, but I think we need a few more just documenting that music is critical to this new paradigm. Then I think we can get into sorting out, whether it's Pink Floyd or Metallica,
Yeah. What type of music do you guys select when like a patient wants, for you to select the music?
In my training, both in experiences, both with holotropic breath work and the MDMA work and the training through MAPS. So in this frame of reference, we believe that music is a carrier wave. Music is crucially important. That we don't want music to drive or channel the experience too much, so that we don't want music with lyrics. We don't want music that is really well known to the person. We clearly don't want most of the existing pop or rock music. So classical music, ambient music, and I think there's just a whole range of music that is in these realms. In fact, music in foreign languages can be really beautiful and experiential. Traditional music, drumming. There's just a massive range of music, and we have fun playing around with it. But I think, to my mind, the main thing is to get it out of the person's usual frame of reference and put something in that can be positive and supportive without being too directive.
Awesome. That's great. Yeah, we use a lot of, say, foreign or traditional music, world music in our breathwork sessions. Just anything with language seems to pull somebody out if the language is familiar.
Right, exactly.
Yeah.
We see that too.
And clearly you don't want to play Lady Gaga to a Lady Gaga fan. I was actually going to make a Pink Floyd The Wall joke earlier, but I held back.
All right. Well, I couldn't resist. Sorry.
Thank you. So how long have you been doing treatments in this facility you're in right now, the Wholeness Center?
Wholeness Center has been open for 8 years, and we've been doing, from the very start, a range of innovative things. So these things include IV nutrition, things like IV glutathione, IV Myers cocktails. We do neurofeedback, biofeedback. We use a range of treatments like cranial electrical stimulation, which is a mild form of electrical stimulation of the brain. A lot of our work is non-technical, like just simple things like meditation training, yoga training, working with diet and nutrition. We do a lot of comprehensive testing of blood, urine, and stool. We do a lot of quantitative EEGs, brain maps, and use that to find and direct us towards not only medications or supplements, but also other sort of integrative tools. So we've got, I think, 15 practitioners here and about 9,000 patients right now.
It's amazing. I really like the model. When I was looking at your site, I was like, this is awesome. It's very holistic, and I think that's really important.
Yeah, thanks. We really believe in the holistic model, and I think this really fits well with the work with ketamine and MDMA because you're really trying to engage the whole person and trying to catalyze deeper whole person healing. And I think that's the value of psychedelics. I think that's the value of these tools, is they're really evocative tools, not suppressive tools. And I think the suppressive therapy in psychiatry is dying right now. And I think we need another paradigm to replace it with. And I think psychedelics represent one strong candidate.
Yeah. What part of it do you think that's dying? Just the suppressive medication side of psychiatry? Like, what do you see the future as?
Yeah, I think there's a lot of psychiatrists that have now seen the research, like in Robert Whitaker's book, Anatomy of an Epidemic, where he documents the failure of long-term medication to really resolve problems. And in fact, it looks like the long-term use of things like antipsychotics or benzos actually make people worse in the long run. Because when you suppress the body's own ability to express symptoms or perhaps heal itself, you're perhaps limiting recovery and limiting what the body can do. So I think increasingly people in psychiatry are seeing that medication management does not solve problems. And just because we have excellent job security and that people come back to us every month needing a revision of their chemical imbalance, it's not really providing the cures or the long-term resolution that we indeed embrace and desire. So I think what we're going to see over the next 10 years is an increasing number of research, particularly long-term research, that refutes the value of medication management in psychiatry. And don't get me wrong, I'm not anti-medication. I write prescriptions every day. I think they're useful tools. I think they can do things to help people. But I think they're most useful in the short run. And in the long run, I think we need better tools that enable growth, healing, and resolution.
Yeah, I think I mentioned this, and I've talked about it before on the podcast, so some of the listeners know, but I worked at this house called Soteria, and it was, a pure respite house for people with early episode psychosis, and it was based off of the early work of Lauren Mosher with the Soteria house out in the Bay Area. People were thinking that it was like kind of anti-med, but we weren't, and we were seeing people come in there that were catatonic, and I think part of that was coming, like, withdrawing from their medication, and finding that, we like this kind of spiritual emergence model or just being with somebody, but sometimes it was really important for somebody to be on meds for a very short time to get sleep and just suppress some of that difficult stuff that was coming up.
And the other thing about medications is that the brain adapts to medications. The brain is plastic. And when someone's been on psychiatric medications for 10 or 20 or 30 years, you may or may not be able to get off those easily. And certainly it's going to be a long process. So I work with a lot of people about getting them off medications and on to more natural approaches. And sometimes it's a 6 to 3 year program. And you have to be cautious and be supportive and know that you have other tools in place to support them.
Yeah. Yeah. To jump back to ketamine a little bit too. So what's the difference between the IV, IM, and oral? Are there different experiences with it? Would you use one type of administration versus another for a particular reason?
I think we're just beginning to explore that. So I offer all three. And most of the people working with ketamine do either IM or they do IV. And I'm bimodality, I guess, and that I like to go back and forth. And I find there's value because each is different. So the IM path, I think, gives a rapidly accelerating experience that takes people out of their body, out of their frame of reference, and into the transpersonal and beyond realms. It's rapid. It can be overwhelming, particularly if people don't have a little bit of experience in this area with something more internal like that. But in terms of the power and the sort of realms that you can go through, the IM is like the rocket ship. The ride goes up, goes to a crescendo, and then down fairly rapidly. Where with the IV, it's a gradual ride up. It holds at a moderate level and then comes down. So in ways, it's much more pleasant and comfortable. It's less transpersonal, typically. I think it may be a little better for the euphoric and suicidality piece. I don't think it's as useful for dealing with trauma issues. And my sense is it's better for the uninitiated. So often I start a person, unless they're really just particularly coming to me for psychospiritual exploration and have some background and want particularly to do an IM modality. I'll often start people with an IV for 1 or 2 sessions, see how they adjust, encourage them to try the IM. We do the IM, and then the last few sessions we discuss and decide, and typically this is in the midst of a 6-session protocol, 2 per week over 3 weeks. And then the oral modality, they come in, I prescribe sublingual oral lozenges that they bring in with them. They put them in their mouth during the session. They go through the experience with me. We talk about it afterwards, process what it was like and get a sense of it, and then decide whether this is feasible for them at home or not. And so those are really the 3 methods. And one of the things that I'm so excited about, I just came back from this group, I think I'm going to be starting to do some group sessions with ketamine and the oral modalities. And that way we can make it much more cost effective for people. Because right now, the IM and the IV is fairly costly because of the technology and the time. I mean, the IM is 2 hours of my time, and I'm discounting my time quite a bit compared to my other office charges just because I enjoy this so much more. But it's nonetheless, IVs run anywhere from $400 to $800 around the country from what I've heard from people for a single session. The IMs range from, most of them are sort of $600 to $1,200. I'm probably underpricing myself, but I'm still on a learning curve with this, and I'm still trying to really mostly use it with my existing patients or patients here at home.
That's per injection, right?
Per injection.
And how does insurance work? Is it working yet?
No.
Okay.
So insurance will cover the medication at home. Insurance is not covering the ketamine IV. Insurance will cover some of my time if I'm processing and doing psychotherapy with someone, but not so much the injection or the time to sit with them.
Huh, that's interesting. But they'll kind of cover the oral doses?
Because ketamine is actually dirt cheap. It's a generic medicine, has been around for a long time. No one holds a patent on it. So to get the lozenges for a month's worth of use may only be $40 or $60. Has to be compounded. It's not something that's made by a big pharma, but a compounding pharmacy will typically make them up for us.
Interesting. And do you have any concerns with people taking home like oral doses?
Yes, I do.
Yeah. And what does that look like for you?
Well, I mean, you worry about the drug being misused, friends coming over and let's have a party. That's sort of the worst case scenario. You worry about someone going into their cabinet and stealing it, which happens all the time. You worry about it being lost, in quotes, so to speak. I explain to people that if they lose it, gets misplaced, whatever, then it's not happening anymore for them. So, yes, I have grave concerns with it, and I don't do this with everyone. I have to have a good deal of trust and a high amount of rapport with someone to suggest this option.
Yeah, that makes sense. And what about like setting? Do you go over that with folks for like take home? Of like, this is like a suggestion on how you would do this?
Yeah, I mean, I try to tell them I want you to have a calm environment. I want you to have a sitter in the room or nearby, music, shade set up, comfort, and, really do this with a bit of forethought and a bit of mindfulness, trying to set up a positive experience. And one of the things we do in-house is trying to set up an intention for each session. And what do you hope to get out of it? And what are your goals? And how do we begin to dial it in for you in a way that can bring the most back?
Fascinating. This is kind of making me think of like the future of psychedelics. Do you think, I know MAPS has talked about having these centers where people could go for, say, psycho-spiritual like exploration at some point and also do the psychotherapy. But do you think like that would, in your vision, like a take-home dose of like, say, mushrooms and like with trust that somebody would do that in a safe setting?
Possibly. I just saw that there's a referendum to legalize mushrooms in California. So someone just sent me that email. So who knows whether it'll be just truly recreational and open season like it's sort of with cannabis here in Colorado, the Wild West, the frontier, or whether it'll be something more thoughtful. For example, when if MDMA goes through the phase 3 process now and receives a legal indication, it'll likely be done only in settings like Wholeness Center, where it will be taken under supervision of a medical provider, and there will be no take-home medicine at any point, at any time for anyone. So that's one model. That's the most restrictive model. And the sort of cannabis open season model is the other end of the spectrum. I would say that even if many of the psychedelics are legalized, I think there's probably still a role for creating a therapeutic venue, or a retreat setting where people go with preparation, with almost clear spiritual intent, maybe fasting, maybe a lot of other things that are done with it that can really begin to amplify the value and potential of psychedelics. So that's what I've been thinking about. And actually, a number of my colleagues and I are talking about how do we create a center for the next phase, the next paradigm in psychiatry, and what would that look like? And I think all of us see the value in having an outpatient center, not unlike what we have with some adjustments, but also the value of having a retreat center that's more a destination place that people would go, perhaps experience a few different psychedelics and psychoactive agents, and realizing that there's a big world out there, and there's actually skill and expertise that professionals can bring to this for the average layperson who wants to do something more than just simple recreation.
Do you ever have people come to you asking like how to get involved in the psychedelic world? And do you have any standard advice you give out?
Yes, I find that happens all the time. And I think, number one, just doing some reading and background work in this area is helpful. So you sort of know the discussion. I think beginning to join relevant organizations that are trying to promote these activities. I think plugging into communications and vehicles such as the one you guys are so wonderfully representing and bringing to the world is another way to get that information out there and share it. Because I think this is an area that's growing rapidly, and it's hard to stay on top of all this. I think going to conferences such as the Horizon Conference in New York, the Psychedelic Science Conference, other conferences that begin to explore these tools, and then finding out places that are working with it and seeing if there's any volunteer options. So I know that we've got volunteers who are going to be sitters for our MDMA trial. And I think as this begins to roll out, there'll be more and more options and venues. So there's no clear path, but I think there's lots of options. And find a mentor, find someone who's experienced or knowledgeable in this field and pick their brain.
Yeah, there's so many paths, right? You could do advocacy, medicine, you could be an assistant or a nurse. you could simply, I don't know, drop off and go to Peru and do ayahuasca all the time.
Oh, there's one other. There's the Center for Integral Studies in the Bay Area has a psychedelics psychotherapy training program. And that I've heard a lot of good things about. At some point, I think MAPS will be doing more training programs. And I think it's likely that when MDMA and perhaps psilocybin roll out of phase 3 studies, that some of the control will be whether people have been through an accredited psychedelic psychotherapy training program. So that's another avenue.
Well, that's interesting, Kyle, because you've been through a bunch of the training already. And it would be kind of a interesting plot twist if they forced you to go to CIIS after you've already graduated from your program and finished all the MAPS training too.
I wouldn't mind it.
Hey, what's money?
Oh, yeah, I guess that's the thing too.
I love student loans. They're my favorite. So what else excites you in the ketamine world right now, Scott? Are there some other interventions other than depression or anxiety, like for alcoholics or?
Yeah, I think the whole area with substance abuse, building on the 1,000+ studies we had on LSD in the 50s and 60s that showed really solid promise. And I think Stephen Ross at NYU and others are really bringing the whole idea of psychedelics and things like ketamine back to the application with substance abuse.
Right.
So it's ironic that a drug that is abused like ketamine could be a tool for treating substance abuse, but I think that is something that's being actively researched. I'm profoundly interested in that. I'm really interested in the idea of trying to take ketamine out of the realm of just significant psychiatric illness and into the realm of personal growth. And so that's an area that I'm really intrigued by, that someone doesn't have to have treatment-resistant depression or life-threatening substance abuse to get ketamine treatment, but they could come in really just for personal growth and personal exploration. And informed consent is important, but I think people can be empowered to make their own decisions. That's one piece that really excites me and interests me. And I just think that at this point with ketamine, with a whole range of things, I think it has potential because it is such a profound yet non-specific brain intervention that it has the potential to open up a number of different realms. So stay tuned.
Are you familiar with people who are working on, I guess what they're calling like the psychedelic 12 steps? So it's kind of like an AA that includes psychedelic interventions.
I don't know of that.
So that's happening out in New York, I believe. Dimitri Mujanis, who works heavily in the Iboga world, and a few others are developing that. And I think there's a smaller community developing there because that's always quite the bridge, right? Like alcoholics really need a lot of help. Even if they're sober, they still need some sort of continued therapy and care. AA isn't always enough. AA is quite the divisive subject. It's always like, oh, it's the best thing in the world, or it's quite subpar. And I don't have a firm opinion on that, but I think psychedelics, if introduced well and skillfully, could really reduce relapse.
Well, Bill W., who founded AA.
Yeah.
I don't know if you know that story, but he first began to explore this idea with Carl Jung. And Jung's response back to him was the only cure of dipsomania is religiomania. Basically, dipsomania is alcoholism and religiomania is religious immersion. And so Bill W. really crafted AA to be a non-religious spiritual immersion for people. And then in the 1950s, Bill W. became acquainted with some of the Canadian researchers doing alcoholism research and had his own LSD experience and really felt like LSD was an avenue that could be very useful for AA. But by that time, AA was an institution beyond him that really resisted this intervention. So, yeah, I would agree that I think there's a strong avenue for psychedelics to be a tool to help substance abusers see their life in a different way.
Yeah. There was what was the guy's name? Russell Brand. You guys familiar with him? British comedian. Pretty funny, a little crass, former addict. He just came out with a 12 Steps book. And he's very anti-psychedelic for himself right now. But Joe Rogan kept kind of prodding him. Why don't you try some DMT? I felt kind of bad for Russell. I was like, shit, man. Like That's kind of a hard step. Like you're going to go from like being sober to smoking DMT, and you're going to get pushed by Joe Rogan to smoke DMT. I think that's a little much. But it was very interesting to hear Russell's position because he wants to try it so bad, but he's just like, I can't do it.
Yeah, see, I think for a lot of people with substance abuse issues, you might want to relegate it into a setting, almost an institution, where it's done in a more structured way with supervision, support, and taking it out of the realm of, hey, I think I'll try this myself. Because I think that for people with a substance abuse tendency can be a spiral into problems.
Mm-hmm. I've had this idea for like any of these interventions, they might be more effective if somehow, like in the Esalen days when they could do a 30-day retreat or something, if we can figure out a way to get somebody out of their normal context for 30 days, we might be able to have deeper patterns, better, more stable ruts that you want to stay in, laid down. And
I think it's in some ways just honoring the shamanistic roots that lie at the basis of a lot of this and really figuring out how set and setting structure. And, one of the pieces about shamanistic work is you don't just do it when you want to. Mm-hmm. You do it in preparation. There's often fasting, and there's often sort of a group process built into it as well. So I think we have a lot to learn from our traditional forebearers.
Yeah, thanks for mentioning that. I'm there with you. But also, you mentioned like a retreat center, and, I'm thinking about like rites of passages. There's that separation phase where you need to separate from your daily life. You need to have like time away. And that also kind of bleeds into like that stage of liminality if you introduce a plant substance as well. But it's really that separation and that coming home as well with the group process with the elders and the community supporting you.
No, I think it's crucial. I think that's somehow wired into our DNA in some way.
Any, say risks or concerns with any of this work that you're doing with ketamine?
Well, I think this is true of all the psychedelics, and with ketamine, is that I think it's possible for people to have harmful effects from it. And I think we know a little bit about who may be at risk for that, but I don't think we know enough. So I think there's still room for caution with this. I think particularly with people with severe psychiatric illness, we need to make sure they try things that are more proven and have documented safety records first. I don't think this is, because there is a risk with it, I don't think this is a first line of approach. And I think we need to continue to grow and support the research, and I think we need to continue to train clinicians and explore the edges of this, because I think it's not just about research, but it's also about clinical exploration, because research and clinical exploration are the two halves of the coin that drive our growing knowledge, and we need both. And we can't just step back and wait till researchers at NIH deliver us the final results of what we should do with ketamine. I think we need an active clinical population that's working this and can come to the researchers and say, you really need to try this with X, Y, or Z at these doses and in this model. So it's a dialogue between the clinicians out doing the clinical work and the researchers and documenting with good scientific clarity what works and where the risks are. So that's my thought about it.
Yeah. What's your take on, I think that some clinics don't have any like processing or say psychotherapy integrated into the ketamine sessions or maybe afterwards. What's your take on just going to a place like that where there's no like integration of therapy?
Well, what I would tell people is that there are a lot of providers out there. Research, I think in most major metropolitan areas now, you'll find options. It may be worth traveling to the kind of providers that you want to see. But there'll be times when it just makes most sense to try what's available if it is a strong need and there are restricting circumstances. But I think what we're seeing now is just an explosion in options, and I think a strong interest in developing the whole side of ketamine-assisted psychotherapy. But that aside, I think that ketamine IVs offer good benefit to people and a reasonable tool to look at if that's what you've got.
Mm-hmm. Yeah, I would totally agree with that. It might be suboptimal, but we still think it's pretty effective. Needles are, for the most part, safe. You're exposed to very little risk with needles for the most part. And, why not? And even lozenges, right? Like if you could come to a clinic like once or twice a week just to eat your lozenge or something, that might be a really cheap and dirty way to do it. As a clinician, setting up a supervised group room like you're doing, I think sounds like a great idea.
And I think we need to be more aware of the access issues with this medication and with psychedelics in general. And that's why I think oral lozenges and group work can create some leveling of the playing field so that people from all backgrounds can experience these options and there's not some elitism. And although I realize there is elitism in this area now, I feel such a strong compulsion. I just feel compelled to bring this work forward. And that's the way it's being done right now. So I think we need to think about access issues with psychedelics and with ketamine.
Yeah, so we're hearing the $10,000 number from MAPS. I think it's probably for the whole course of the treatment. So probably some non-drug psychotherapy before, during, and after your MDMA sessions. And I think it was 3 to 6 MDMA sessions or something. So I think that's kind of a fair number in a lot of ways.
One of the things we're seeing with the MDMA therapy is people get 65 contact hours of time. So that's expensive. I mean, that's a lot of professional time. That's per professional. So I think we double that. It's 130 hours of contact time in this protocol. And I think it's real clear that we want to make sure and document the value of this process, this therapy, this medication, but also realizing that it's not make for a lot of access options once it's in the marketplace.
So that boils down to $76 an hour, $77 an hour or so if you go to the 130, which is, it's kind of reasonable. It's less than the price of an hour of psychotherapy normally.
Yeah, and if you think about it, it's less than the price of a typical psychiatric hospital admission. and
a lot more effective.
And a lot more effective, and it has the potential for long-term cure or long-term remission, resolution of symptoms. So we're seeing that very strongly.
Cool. And maybe one last question about psychedelic ethics of providers. Are you seeing any kind? So we have the normal standard ethics that therapists, psychotherapists have to abide by. Do you see any additional ethics that have to come into play with psychedelics when you start bolting that in a professional setting? Like one person that we chatted with, I think it was like Larry Norris from Erie in California, talked about how do you even do informed consent with this kind of thing? Like how do you actually get them to understand what they're agreeing to? Because the language sometimes can be so crazy and difficult to match the experience.
I think that's true. So like I said, I do overkill. I send people home a week ahead of time with a 10-page form. I ask them to read it thoroughly, perhaps twice. We spend time discussing it and explore what the options, the alternatives are. I think the other thing about ethics is that we have to think about what are the ethics of having someone who is sort of immobilized and in your office under your supervision and under your care. They're so vulnerable that we have to really think about, we probably need a whole new realm and a whole new model of ethics for psychedelics in mental health. It just creates so many interesting scenarios, concerns, questions, and situations that we need to be very cautious, and I think we need to be on our highest model of ethics. And I know that's the way MAPS is trying to do this and move forward. For example, having co-ed psychotherapy. And that's one way to be very protective. But this is an area that's new, it's novel, it creates new situations that we're not used to in mental health. And I think at times put patients at risk if we don't have the highest ethical standards being upheld.
Yeah, thanks for that. Yeah, so at about an hour, do you have anything you might want to throw in at the end here as kind of a way to wrap up?
Well, I think that my enthusiasm at times may lead me as I'm exploring these new realms, but I think it's important that we understand the research, we understand the limitations, that we're cautious in trying to make broad references that this can benefit everybody. I certainly have people that it has failed, and I think I'm concerned that we still don't understand the potential risks, although I think we have a pretty good idea. But it is a frontier, and many people are suffering so greatly with depression and have failed so miserably with conventional care. They're looking for options. But I think ketamine is a very promising and novel approach that has the potential not only to shift psychiatry, but really to shift our framework about personal growth and I think really help to open up our understanding of psychedelics in general.
Yeah, totally agree. They do appear to be a growth agent for humanity as a whole as soon as they're legal. It's going to really shift a lot, I think. Maybe slowly, but we are going to see some pretty big leaps and bounds in different areas.
And I'm just so excited about the work with MDMA because I think that will be one that will bring the notice from psychiatry in general. And I think it can really begin to shift how we care for people in need.
So you said you were the PI for the Fort Collins site?
Yes.
Oh, that's fantastic. As that goes, we'll have to check in with you.
Yeah, happy to share.
Yeah. Well, Scott, Shannon, thanks for your time. We really appreciate it and looking forward to chatting again soon.
Joe and Kyle, thanks for the invite. Happy to be here.
Odds are good you've been in a strange situation regarding somebody handing you some drug and you didn't know how to use it. Even if it was, you were 17 years old and somebody handed you a joint and you go, doesn't this make me go crazy? How do you level up your knowledge and get a handle on what drugs are safe, how to do drugs, how to know if this stuff is okay to do? Like, does LSD cause chromosome damage? That big lie from the 60s, 70s. And, it doesn't. So how do you clear these things up? Kyle and I developed a class, Navigating Psychedelics, and it is, consider it a 101, 102 of psychedelics. How to do them, how to be safe, how to make sure you and your friends don't go to prison or go to the hospital. And we walk you through a lot of that process. We do some live support through our secret and closed Facebook group. There's also the ability to communicate inside the course. We are going to start offering regular live check-ins, webinar check-ins to folks, and that can really help support the process. So far, the feedback has been tremendous. People are very excited about the class and are shocked at the amount of value we've thrown in there. We did a whole bunch of master classes with experts in particular sub aspects of psychedelics. The folks who are featured as masterclass teachers, Lenny Gibson, PhD, Elizabeth Gibson, those are both our breathwork teachers, Larry Norris from Erie on integration, Paul Austin on microdosing, Shannon Claire Carlin, she works for MAPS, she's great, Catherine McLean, PhD, Ashley Booth, MS, Neil Marshall Goldsmith, PhD, Mitchell Gomez, Executive Director of Dance Safe, Julie Megler, MSN, so she's a nurse practitioner that also works at Erie with Larry Norris. Dr. Richard Grossman, who's a acupuncturist, he's got a PhD on ayahuasca, light hearts and safety, we called that one. Ville-Marie Narlock from the Students for Sensible Drug Policy. Michelle Hobart, MS, Spiritual Emergence and Self-Care. Dr. Ingmar Gorman, clinical psychologist who works closely with Catherine McLean in New York. And that's it for now, but we're going to keep adding more. I think we're going to get one with Daniel McQueen soon, so keep an eye out for that. And I hope you have the opportunity to check it out. If you want to get better educated on psychedelics, this is a great way to start. Even if you've been around for a long time, you might have picked up some, hippie wisdom or something that might not necessarily be right, about brown acid or black acid or whatever. Kind of all just one molecule. You can test for that molecule and know that you've got a molecule. Maybe there's some side additives, but this is stuff that we really need to figure out and get straight. We need a baseline of knowledge as a community here, and this is our contribution to that. So you can learn more at psychedelicstoday.com. And if you want to go right to our site, it's psychedelicstoday.teachable.com. If you are interested in doing legal psilocybin mushroom work in Jamaica with an expert, you really want to go check out Eric Osborne. You can find him at mycomeditations.com. Coming up in late November, I think right after Thanksgiving, you can go down to Jamaica, work with him, and do some serious inner work on yourself. Mushrooms do allow really great access to your inner landscape, and doing it on the beach in a beautiful environment in Jamaica is a great spot to do it. I really do recommend Eric Osborne, and you should check out a couple of our past episodes with him if you want to get a feel for him personally. I really do appreciate what he's doing and can't wait to get down there. Coming up, this November retreat will feature Catherine McLean, PhD, and Shane Moss, the comedian. There's also another comedian, don't know the name, but you should check that one out on their site because that could be really special. Catherine's going to bring a lot of information about psychedelic safety and integration practices. Shane is going to talk at length about his healing process and explorations through psychedelics. The last podcast we did with Shane, Eric helped us there. It was really fun because Shane got into a lot of the funny, great parts of psychedelics and also some of the scary parts. You know, having people that have that knowledge available to help guide you through this stuff is great. And Eric's been through, has been doing this for an incredible amount of time, so he's a pro. What's the thing? 20,000 hours? Yeah, whatever that rule is of you put in so many hours of practice to get to this expert level. He's at about master level, so, you're probably going to want to check him out. If you don't want to go do ayahuasca in Peru your first time, maybe you want a shorter flight from the US or Europe and you don't really see the need to go upriver in a little boat, maybe this is for you. Yeah, again, mycomeditations.com, and you can learn a lot more there, mycomeditations.com. If you have any questions about it, feel free to email us, psychedelicstoday@gmail.com. Hope you check it out. If you want to look really cool in some Psychedelics Today gear, you really want to check out psychedelicstodayshop.com. We've got all sorts of cool stuff, from t-shirts to mugs to shower curtains and pillows. So you check it out. Any small purchase helps, even if it's just some stickers. We got some cool stickers there. Check it out, psychedelicstodayshop.com. Tell your friends. Maybe buy some presents for this upcoming, what do you guys call it, Black Friday? Yeah, Black Friday. Maybe that. Or maybe it's a Christmas present or whatever. We would love you guys to check out some of our stuff there and support the show. Thanks.